Hello everyone. In this video we are going to study about Lscs, that is lower segmental caesarean section. I am S. Ruth Casey. I am working as a tutor in Tripoli College of Nursing. So in this video we are going to learn about the definition of Lscs, types of Lscs, indications and contraindications of Lscs, advantages and disadvantages of Lscs, steps of Lscs, caesarean hysterectomy, caesarean sterilization and complications of Lscs. So a cesarean section is an operative procedure to deliver a viable fetus or more, that is or more, okay? And the weeks will be to 28 weeks or 20 weeks of gestation through an abdominal uterine incision. The primary goal of cesarean delivery is preservation of life and well-being of both mother and fetus. That is, we are delivering a baby which is after 28 weeks. So it should be after 28 weeks or more than 20 weeks of gestation. Okay. Incidence. Incidence is from 5% in 1970 to 25% in 1990 and continues to rise globally. Now accounting for more than 1 in 5, that is 21% of all childbirths. This number is set to continue increasing over the coming decade, with nearly a third, 29% of all births likely to take place by cesarean section by 2030, the research finds. This is due to procedures such as high forceps, mid forceps are abandoned in favor of cesarean section, increased cesarean section in breech deliveries, destructive operations are abandoned in favor of cesarean sections, decreased morbidity and mortality due to CS encourages its use. Increased repeated CS due to increased primary CS. So these are some of the reasons of increased incidence of cesarean section. So in indications, we have maternal indications, fetal indications, and previous cesarean sections. So the indication is divided into 3 subtopics. First, we'll see about maternal indications. Under that, it comes contracted pelvis. That is, the pelvis will be smaller than the size of the head of the baby. So we call it as cephalopelvic disproportion. And pelvic tumor, especially if it impacted in the pelvis or cancer cervix. So the birth passage is primarily obstructed here. And antepartum hemorrhage. So in case of antepartum hemorrhage, we expect the placenta to lie in lower segment. So when the head presses onto the placenta, there will be more bleeding. So before delivering the baby, the mother will die of hemorrhage. So antepartum hemorrhage is one of the indication for cesarean section. And hypertensive disorders with pregnancy, abnormal uterine action, previous uterine scar as hysterectomy or metroplasty, previous successful repair of vesicovaginal fistula. So these are some of the maternal indications of cesarean section. Next comes the fetal indications. So in fetus side, these are the abnormalities we decide to go for cesarean sections. The first is the malpresentation and malpositions. So babies, the normal presentation is LOA. Okay, the normal position is presentation is vertex, that is head presentation. The position is LOA, left occipital anterior. So the position or presentation other than is considered, everything is considered as malpresentations and malpositions. In these cases, we take the patient for cesarean section. Next is a prolapsed pulsating cord or fetal distress before full cervical dilatation. So what happens if the cord comes out? It is obvious that the blood supply to the fetus is in jeopardy. It is compromised. The blood supply is not there. So we take the cesarean section within minutes. And next is a diabetes mellitus, bad obstetrical history. So in this case, we consider this pregnancy as precious and we wanted to save the baby. So they will take as an elective cesarean section. And next is a postpartum CS for a mother who is dead and we want to save the baby. So postmortem CS is done. Next category is the previous section, cesarean section. So these are some of the indications of cesarean section. Under previous cesarean section, we have contracted pelvis. Previous section was upper segment, and suspected bleeds are as evidenced by history of puerperal infection, Hysterosalpingography or hysteroscopy done after the previous section reveals a defect in the scar, and vaginal bleeding during current labor, marked tenderness over the scar during current labor, associated conditions as antepartum hemorrhage or malpresentation. These are some of the indications of the cesarean section. Next, we'll see about the types of cesarean section. So here also we classify the cesarean section types according to various criteria. First is according to timing. It is elective cesarean section or selective cesarean section. Elective means the operation is done at a pre-selected time before onset of labor, usually completed at 39 weeks. Okay, so before there is pain. Okay, onset of labor means the mother will not have pain. So before that we decide some time, some auspicious time, maybe the patient selects the time, and that time the elective cesarean section is carried out. Next is the selective cesarean section, is an operation done after the onset of labor. Okay, after the pain arises, we go in for the cesarean section. Next, according to the site of uterine incision, the cesarean section is classified as upper segment cesarean section. The incision is done in the upper uterine segment and it is always vertical. And the first is upper segment, the second is the lower segmental cesarean section. It is a commoner type. So in all the case, we go in for the lower segmental cesarean section because of some cosmetic reasons. Okay, the incision is done in the lower uterine segment and may be transverse or vertical in following conditions: the presence of lateral varicosities, constriction ring to cut through it, deeply engaged head. Okay, so these are the lower cesarean section. So if you see in the picture, the first is a lower transverse incision, the second one is a lower vertical incision, and third is a classical incision, that is the upper segment. The third one is the upper segment cesarean section. So this is according to the type of incision. Now according to the number of operations, we classify cesarean section as primary cesarean section and repeated cesarean section. Primary is doing it for the first time, the repeated cesarean section with the previous sections. Next, according to the opening of the peritoneal cavity, this is not done often, so you have to know for the theory purpose. So according to the opening of the peritoneal cavity, it is classified as transperitoneal and extraperitoneal. Transperitoneal is the operation where the peritoneal cavity is opened before incising the uterus. Extraperitoneal, the peritoneal cavity is not opened and the lower uterine segment is reached either laterally or inferiorly by reflecting the peritoneum of the vesico-uterine pouch. It is indicated in case of infected uterine contents as chorioamnionitis. Okay, so if we suspect some of the infection into the uterus because of chorioamnionitis, so we don't want the infection to spill into the abdomen, to get in spill into the gut, that is intestines and the other vital organs into the abdomen. So we want to protect the other vital organs. So this peritoneum is reflecting from the vesico-uterine pouch, and we are taking the contents of the uterine content without spilling into the abdominal cavity. So that is called extraperitoneal cesarean section. So next we'll see about the advantages of cesarean section. First is preoperative good preparation as regards sterilization and antiseptic measures, fasting and bowel preparation. And so we are preparing the patient well, okay, for sterilization and everything. And there is puerperal sepsis is minimized because it is totally a sterile procedure done by the registered medical practitioner, and the operation is scheduled and working easily. So we always schedule the surgeries like elective cesarean. It is always planned ahead, that is previously it is planned, so the work will be at ease. So sorry, disadvantages of elective cesarean section: the risk of immaturity of the fetus or its lung is present, the higher incidence of respiratory distress syndrome, lower segment may not be well formed, postpartum hemorrhage is more liable to occur, imperfect drainage of lochia as the cervix is closed, so it should be dilated by the index finger, introduced abdominally through the uterine incision. So first what it says, the immaturity of the fetus. Okay, the surfactant level of the fetus in the lung surfactant level of in the lung of the fetus may be not well formed. So the alveoli will not be in shape. So the fetus may not breathe. So that we called as immaturity of the lung of the fetus. And higher incidence of respiratory distress syndrome. This may be due to when we take the patient for a cesarean section after the pain arises. So the mother will be in labor, and that time we taking the mother for the cesarean section so many times that will be the liquor will be it will be meconium stained liquor. So in that case, the respiratory distress for the fetus can arise. And lower segment may not be well formed. Well formed in the sense we want well formed means the blood vessels should be well formed in the lower uterine segment. So if you compare the lower and the upper uterine segment, the blood vessels coagulation, the constriction of the blood vessels is well formed in the upper segment, but it is not present in the lower segment. So okay, so if the lower segment is not thick, okay, if it is thick, it can clot the blood vessels, it can constrict the blood vessels easily. But if the lower segment is thinned out, it cannot constrict the blood vessels. So if at all there is a major blood vessels present there in the lower segment, then there will be a great difficulty to control the bleeding in the lower segment. And next is the postpartum hemorrhage is more liable to occur. This is because of we are using more of scalpels and the scissors. So there is a chance for to injure the organs. Okay, and next is the imperfect drainage of loci. So if here we are delivering the head above the not through the normal birth passage, right? Here we are cutting open the uterus and delivering the head, and so the cervix now it is the position of the cervix is closed. So after the delivery of the head, that is during postpartum period, there should be a drainage of lochia for 21 days, right? So if it is closed, there is a risk of postpartum hemorrhage. So imperfect drainage of lochia, it will be there. So it should be dilated by the index finger while doing the but before closing the uterine incision. Okay, so that the lochia drains normally. These are some of the disadvantages of elective cesarean section. Next, we'll see about the procedure of lower segment cesarean section. So first is usually the anesthesia will be spinal, okay, because we are dealing with the lower part of the body. So most of the time it is spinal. It may be emergency or elective cesarean section. The most of the time the anesthesia will be spinal, except in the case of mother who are compromised with cardiac diseases, who cannot do some more physical exercises, strenuous exercises, who cannot tolerate them. So we are giving general anesthesia, and for cord prolapse we want to save the baby within minutes. That time we cannot wait for spinal anesthesia, so that time we'll go for general. So some of the emergency cases we go in for the general anesthesia, otherwise it is mostly spinal. The position is tilting the patient 15 degree to the left to the dorsal position, minimize the aorta cable compression. So you all know that the position that is always left side. And skin incision. So this is called a financial, that is transverse suprapubic incision is the most commonly used, but midline or paramedian vertical suprapubic incision may be used if the patient had a previous cesarean section incision in the same incision with the trimming of fibrosed edges of the wound to help good healing. So this is about the incision. Next we'll see about the pictures. So the first picture here, this is the it is like the shape of the incision. If you see, it is like a semilunar in shape. So it is given in the lower part of the abdomen. So this one we call as financial incision. This is the name of the incision is called financial incision. And when we open that skin, if you the yellow part is called the subcutaneous fat. And in this picture 2, you can see the subcutaneous fat is being opened with the blade. The skin is also opened with blade. The subcutaneous fat is also opened with blade, scalpel blade. Okay. So after opening the subcutaneous layer, you have the white layer that is called the rectus sheath. Okay. So the white layer is called rectus sheath, and the rectus sheath is opened. First it is opened with a blade, and then the extension of this opening. So a small nick is given by the blade, and then extension of the nick of the opening is done by the scissor on the either side. Okay, it is extends to laterally on either side. So after opening the white layer rectus sheath, you have the longitudinal muscle fibers. Okay, so this is the longitudinal muscle fibers. We are deflecting the muscle fibers to the either side of the abdomen, that is lateral side of the abdomen. So after the muscle fiber, so this is how we deflect with both hands. Okay, after deflecting, you can directly see the peritoneal layer, and after opening the peritoneal layer, only we deflect it with these hands. Okay, both the muscle and the peritoneal layer will be deflected with fingers like this. And opening the peritoneum, you can see the big uterus. Okay, so this is the uterus, and the incision is made inside the uterus. This is how the Doyne's retractor will be placed. Incision is made inside the uterus, and is again the incision is enlarged, that is a small nick is done by the scalpel blade, and the incision is made enlarged by scissors cutting towards laterally. Okay, so next, and then as in the figure number 9, you can see the head is being delivered from the uterus. So next now we'll see this steps of Lscs one by one. So first, the financial incision has a better cosmetic appearance, better healing, and less incidence of incisional hernia. But it is more time consuming, associated with more blood loss, and gives less exposure. Then subcutaneous fat is incised. The anterior rectus sheath is incised transversely in case of financial incision, and longitudinally in case of vertical incision. The rectus muscles are separated in the midline in financial incision, or retracted laterally in case of vertical incision. The peritoneum is opened vertically. Next, the uterus is centralized. The bowel and the omentum are packed off with the moisture laparotomy pads. However, this is usually unnecessary. The loose peritoneum over the lower uterine segment is held and incised transversely for about 10 cm in a semilunar fashion, with its edges directed upwards. And the bladder is dissected downward and is retained behind a Doyne's retractor placed over the symphysis pubis. A state suture may be taken superficially in the lower uterine segment below the assumed site of uterine incision to help in its identification after evacuation of the uterus. The uterus is incised in the semilunar fashion by one of the following methods. A semilunar mark is made by the scalpel cutting partially through the myometrium for 10 cm. A shortcut, it is made in the middle of the insertion mark, reaching up to but not through the membranes. The incision is completed by the two finger along the incision mark. If the lower uterine segment is very thin, the injury of the fetus can be avoided by using the handle of the scalpel or a hemostat, that is artery forceps, to open the uterus. Next, the short middle incision may be enlarged by a bandage scissors over two fingers introduced into the uterus to protect the fetus. Next, the membranes are ruptured by toothed or coccus forceps. The head is delivered by introducing the right hand gently in and lifting it up, helped by fundal pressure done by the assistant, using one blade of the forceps or using Wrigley's forceps. If that head is deep in the pelvis, it can be pushed up vaginally by the assistant. The Doyne's retractor is removed after the head or the forceps blade is applied and before the hand extraction. So before delivering the head, the Doyne's retractor, which is retracting the bladder, should be removed. So then only the head should be pulled out from the uterus. Suction of the fetus is carried out before the delivery of the head. So once we see the mouth of the baby, we have to give the suction. In breech or transverse lie, the fetus is extracted as breech. The placenta is removed. The closure of the uterine incision is done in 3 layers. The first is a continuous locking suture, taking most of the myometrium but not passing through the decidua to guard the cord against endometriosis and weakness of the scar. Second is a continuous or interrupted one inverting the first layer. The third is a continuous or interrupted layer closing the visceral peritoneum of the uterus. Closure of the visceral or the parietal peritoneum is omitted by some surgeons. The abdomen is then closed in layers. It means the peritoneum, the muscle, the rectus sheath, the subcutaneous fat, and the skin. So I'm saying from down above. So in this order, the abdomen is closed in layers. Now let's see about the upper segment cesarean section. So indications of this are dense adhesions, extensive varicosity or myoma in the lower uterine segment, making its exposure or incising through it difficult, and impacted shoulder presentation, anterior placenta previa, defective scar in the upper segment, cancer cervix, rapid delivery is indicated. If a concomitant to tubal sterilization will be done, and previous successful repair of high vesicovaginal or cervicovaginal fistula and postmortem hysterectomy. So these are some of the indications of upper segment cesarean section. Now we'll see about the procedure. The abdomen is vertical and uterine incision. So as you see in the picture, the vertical incision, this is the incision given for the upper segment uterine upper segment cesarean section. That means it is if you see, it is slightly deflected towards the right side of the umbilicus. It may also be called as right paramedian incision. So uterine incision is 10 centimeter. Vertical incision is made in the midline of the upper segment without incising the peritoneal cavity separately, as it is adherent in the upper segment. Extraction of the fetus as a breech in cephalic presentation. The last layer of the uterine incision closure includes the superficial part of the myometrium with peritoneal covering. The remainder of the procedure is as a lower segment cesarean section. So now we'll see about how lower segment over upper segment is benefited, has more advantages. Less blood loss due to less vascularity, and the placental bed is away from the incision, easier to repair. The resultant uterine scar is stronger, less subsequent adhesions to the bowel and omentum, less liability to acute gastric dilatation and paralytic EDs, and less liability to peritonitis due to peritonization and healing. So these are some of the advantages of the lower segment over the upper segment operation. Next, we'll see about the cesarean hysterectomy. So when we will do hysterectomy along with cesarean section. Hysterectomy is carried out after cesarean section in the same sitting for one of the following reasons. First is uncontrollable postpartum hemorrhage, unrepairable ruptured uterus, or operable cancer cervix, covalent uterus, placenta accreta cannot be separated, severe uterine infection, particularly that is caused by Clostridium bulli, and multiple uterine myomas in a woman not desiring future pregnancies, although it is preferred to do it 3 months later. So these are some of the indications of cesarean hysterectomy. What is cesarean sterilization? A tubal sterilization is usually advised during the second cesarean section. So along with the cesarean section, if the baby is second baby and the first baby is alive and well and thriving, and if the mother and the family gives consent, we will go for the tubal sterilization along with cesarean section. So in one setting, 2 procedures will be done for the mother. Now we'll see about the complications of cesarean section. First is operative. The primary maternal mortality is 4 times that of vaginal delivery, which may be due to shock, anesthetic complications, hemorrhage due to extension of the uterine incision to uterine vessels, and atony of the uterus or disseminated intravascular coagulation. These are some of the reasons of these are some of the complications during the cesarean section, that is primary complications. Next is injuries to the bladder. So we are deflecting the bladder with a Doyne's retractor. So there may be some injuries to the bladder, but it does not occur usually. Next is fetal injuries. Postoperative complications are divided as early and late. First is thrombosis. Under early we have thrombosis and pulmonary embolism, acute dilatation of the stomach and paralytic ileus, wound infection, puerperal sepsis, and burst abdomen, and chest infection. So the thrombosis and pulmonary embolism and chest infections are mainly due to immobilization of the mother, and acute dilated paralytic ileus may be due to injury to the bowel, which we while handling the organs inside the abdomen. Next is wound infection, that may be due to many reasons. Primarily, if the mother personal hygiene is not maintained well, so that may most of the case there will be wound infection in spite of giving good antibiotics and everything. And late complications are rupture of the uterine scar and incisional hernia. So to summarize, in this video we saw about what is this LSCs, that is what is cesarean section, lower segmental cesarean section, the indications, the contraindications, the advantages, disadvantages, the procedures step by step of a lower segmental and upper segmental cesarean section, and complications of cesarean section. So I hope you all enjoyed this video and gained some knowledge about cesarean section. Thank you.